come to the peer review session. It's a pleasure to see everyone. I know everybody's had a very long and busy meeting, so thank you for attending. Today's session is called Making Headway Towards Better Outcomes in Intermediate to Advanced Stage Hepatocellular Carcinoma, a multidisciplinary tumor board on implementing novel, local, regional, and systemic approaches. My name is Salem. I'm Chief of Interventional at Northwestern. We have Goya, who is medical oncology at Mass General, soon to be at Stanford, and Singal, who's head of liver cancer at UT Southwestern. It's a pleasure for them to be here with me. Thank you to Medical Learning Institute and PeerView for providing this session, and AstraZeneca, Genentech, and Novocure for providing the educational grant for this symposium. If you haven't already done so, please complete the pre-event survey. This is very important to gather information to make these better so that we can extract information and improve on content. Be a reminder, be on the lookout for additional follow-up polling during the presentation. The slide will come up and I'll highlight that for everybody. And then you can submit your questions and we'll answer them during the Q&A period. So please, this is meant to be interactive. We're gonna have some great data sharing. The relationship of what we do as IRs in medical oncology and hepatology. We'll have some tumor boards, show some cases, interested in people's input. So looking forward to that aspect. I remind everyone to visit the website listed here at PeerView so that you can view the slides and obtain other practice aids, and you can download everything pretty much after the event. So HCC is a topic that over the last 10, 15 years, of course, for interventional radiology has become certainly much more interesting. The incidence continues to rise, much as a result of aging, even post-SVR, and also fatty liver disease. So it continues to increase and it'll continue to be an issue that we need to deal with, and recognizing that we need to work as teams and as groups continues to be extremely important. Nevertheless, even with all the new therapies that we are applying, the mortality continues to increase, and this is why we are all committed as a group, as a society, as team members, to really reverse that trend in years to come with all of the therapies and approaches that we have available to us. The flow of patients as they go through algorithms is really multidimensional, and patients will touch multiple disciplines at multiple times. Surgery, hepatology, IR, medical oncology, and back and forth. It's quite a complex flow, it's quite a complex algorithm, but that's the reality of how patients actually flow, and it's important that we all recognize that as contributing members of the tumor board that you'll hear about a little bit later on, to know that this is how patients flow, and we want to maximize all of the treatment options available for these patients. So for today, obviously, we want to have a good discussion. We want to update everybody on the contemporary data that exists in HCC, particularly in some of the systemic therapy options, navigate that landscape that I talked about, that interplay between intermediate and advanced HCC that I think we all encounter at tumor boards. What is the best decision making? What are the good kinds of discussions that can be had when we look at these treatments? And think about all approaches of treatment decision making processes when we think about HCC. And of course, Q&A is extremely important. We have a good 10, 15 minutes at the end to really answer questions. And every time I'm asked to do one of these things, I make sure that we have enough time for Q&A. That's where people really learn. They get their answers, their questions answered by experts that we have here, and really can generate a lot of learning. So without further ado, I'd like to introduce my very good friend, Goya, who'll talk about navigating the therapeutic landscape of advanced HCC. Lipika.
Thank you very much, Riyad. You know, it's really an honor to be here at SIR. And over the last couple of years, I've had the pleasure inviting Riyad and Amit to different med-onc heavy conferences. And I've also had the privilege of speaking at different IR conferences. And I think that really speaks to the multidisciplinary collaboration that we're doing so much more in the last couple of years, because as Riyad said multiple times, collaborating is the way forward for HCC. So as everyone knows, that in medical oncology, there was a long period of barrenness in that we didn't have, between 2007 and 2017, we didn't have any FDA approvals. There are a lot of shots on goal, and what you're seeing here between 2017 and 2020, a lot of that was based on the hard work during those 10 years, so it was not for naught. But really, over the last couple of years, we've started to see many more therapies for HCC. And in 2020 is the first time we had a regimen that finally beat sorafenib. Sorafenib was king for a long time. And the three things we look at as medical oncologists in terms of how we decide on therapy is efficacy, safety, and tolerability. And what we learned with atezo-bev is that it has better efficacy than sorafenib, it has better tolerability than sorafenib, and safety was relatively equivalent. And so that's how we think about treatment. So I'm going to talk about that, and I'm also going to talk about durva-tremi, which is another regimen that was a positive phase 3 trial, and some different things on the horizon. And so this is the modified Bclc staging system. As we know, as we've been using this in HCC for many years, it's a staging system that provides both prognostic information and helps us make therapeutic decisions. As Riyad mentioned, this place right here between Bclc stage B and Bclc stage C, at this interface is where we have a lot of our conversations in tumor board and think about when do we bring in systemic therapy, when do we bring in liver-directed therapy. And a couple of things I wanted to bring up, because I'm going to mainly focus on this advanced stage, Bclc stage C. There are three different flavors of Bclc stage C. One, people who have portal vein thrombosis, and that could be VP 1, 2, 3, or 4. People who have extrahepatic spread, so involvement of lungs, bones, peritoneum. Or 3, a performance status of 1 or 2. And you can have 1, 2, or 3 of these factors and be qualified as stage C. And so what I would say is we're going to go through some cases where people, their only qualifying factor is performance status of 1 or 2, and otherwise they're a B or maybe even an A. And so that'll be an interesting way to think about how do we address HCC in those patients. And the other thing I wanted to bring up is this right here, which is, this is new in the Bclc staging system, which is patients who have diffuse, infiltrative, or extensive bilobar liver involvement. Bclc staging now recommends that we think about systemic therapy for these patients because they don't benefit as much from TACE. So we're going to have a little sparring later on where we discuss a case with infiltrative HCC, and we welcome all your input. As Dr. Salem said, if you have any questions, if you have any thoughts, this is best if it's interactive, so feel free to speak up anytime. So now with the staging system, I'm going to focus right here with people who have Bclc stage C. For a long time with sorafenib, the median survival was less than a year. Now it's considered to be more than 2 years. And what we see in the first line, we have atezolizumab, bevacizumab, we have durvalumab and tremelimumab, and if either of these are not feasible, we still have sorafenib, lenvatinib, and durvalumab. And then I will not focus on second line treatment so much today, but we have a couple of different options in the second line and third line as well. So what's the evidence for supporting the recent changes in the Bclc staging? So I'll first just give one small slide about immunotherapy. So as we all know, the biology for immunotherapy won the Nobel Prize in Medicine in 2018 with Taz Saku Hanjo and James Allison winning this for their work on PD-L1 and CTLA-4. We know that Jimmy Carter got immunotherapy for his melanoma, and it melted away his brain mets. And we know that there have been many, many approvals for immunotherapy throughout oncology. And so there's PD-1 inhibitors and CTLA-4 inhibitors that are checkpoint inhibitors. And the main function of our immune system is to be able to distinguish self from non-self. And while that sounds like a pretty simple concept, Mother Nature has actually developed quite a complex system for being able to help us recognize self from non-self. And our normal cells have these checkpoints, or these proteins, that tell our immune system to stop and not attack so we don't develop autoimmune disorders. But cancer cells are very clever, and they hijack this system, and they have those proteins on them as well. And so that's the way they evade the immune system. And so the PD-1 inhibitors, they work later in the immune response in the peripheral tissues. CTLA-4 inhibitors, this is thought to be the leader of the checkpoints, and it works early in the immune response in the lymph nodes. And so there's these two different classes of checkpoint inhibitors that are effective in HCC. So I'll talk about the two trials, one for atezo-bev and one for durva-tremi. So for the atezo-bev trial, The key eligibility criteria were that patients had no prior systemic therapy for HCC. They all had advanced or metastatic disease. They had a performance status of 0 to 1. And importantly, they required an EGD within at least 6 months. And this is relevant for collaboration with interventional radiology, because sometimes it takes weeks in order to be able to get an EGD. And it's a good time, if we want to get good tumor control, to think about different IR-directed therapy so people don't get in trouble with the amount of burden of tumor they have in their liver. So in this trial, the patients who got atezo-bev had a median survival of 19.2 months. This is a blockbuster over 12 months. I think my friends in breast oncology and prostate oncology kind of laugh at me a little when I get excited about 19.2 months, because of course, luckily in their cancers, people live a lot longer with metastatic disease. But 19.2 months compared to 13.4 with sorafenib, and the response rate was 30%. This was a positive phase 3 trial, and this is why this is the new champion in HCC. In terms of the confirmed overall response rate, 30% with a CR rate of 8% and median duration of response of 18%. It's an amazing feeling in clinic when you can tell a patient that their tumor is shrunk, and especially say, all your tumor has disappeared. It's such a change in being in clinic in HCC to be able to tell patients this, and we have patients 3, 4, 5 years out who are off therapy, and immunotherapy has hopefully cured their disease. Still time to tell, of course. Luckily, within this study, the bleeding rate was not significantly higher with atezo-bev, despite atezo being quite a strong VEGF inhibitor. Of course, again, the EGD was really important, and it also required no recent GI bleeding. And you can see that atezo-bev was overall better tolerated than sorafenib, in that there's a lot more diarrhea and hand-foot syndrome with sorafenib, for example. And then they also did quality of life surveys. As you know, really important part of oncology trials these days is what's the cost of living longer? Do people have poorer quality of life? But in fact, the time to deterioration with atezo-bev was 11 months compared to 3.6 with sorafenib. So in my experience, giving atezo-bev, people tolerate this really well. With Himalaya, this was another frontline trial. Patients got Durva plus Tremi, or sorafenib. This arm was closed because this arm was seen to be more effective. And in this trial, the survival with Durva-Tremi was 16.4 months compared to 13.8 months with sorafenib. Again, a positive phase 3 study, and this is now another good option for patients with HCC. This does not involve any VEGF inhibition, so it's particularly good for patients who have varices or have a history of recent GI bleed. An important part of the subgroup analyses here is that Durva-Tremi, and this is similar with atezo-bev, help patients with macrovascular invasion and help patients with extrahepatic disease. That's important because one thing to remember about systemic therapy trials is these are not trials with patients with liver-limited disease. It includes a lot of patients with widespread metastatic disease. So in terms of cross-trial comparisons with trials with liver-only disease, it's just something to think about. The immune-related adverse events, around 35-36% with dual checkpoint inhibitors. About 20% of patients required steroids. So the take-homes, we have 2 new kids on the block for frontline treatment of HCC. Atezo-bev, 19-month survival, 30% ORR. Durva-Tremi, 16-month survival, 22% ORR.
Thanks, Lipka. That's fantastic. Please, everyone, including everyone that's joined us online, please take a moment to answer the follow-up polling questions on the first-line evidence immunotherapy combinations in HCC. Again, important for us to contribute to that so we can get more information.
And then...
Sorry, go ahead.
Oh, no problem. Thanks. And then I will just end with some emerging approaches in first-line HCC. The COSMIC-312 study has been completed. It showed some activity with an improvement of PFS with the combination of cabo plus atezo compared to sorafenib. The lenvatinib-pembro results are really awaited. It's a phase 3 trial of len-pem versus lenvatinib alone. In the phase 1, there was a 36% response rate. The CheckMate 9DW is a combination ipi-nivo trial. In the phase 1 study, there was a 32% response with this combination. So this is going up against sorafenib or lenvatinib. We're excited for those results. There are also several new early phase studies that are in development and currently ongoing, so many new combinations to look at. So this is my final slide. You know, there are lots of different ways that we can approach patients with HCC. How do we choose between liver-directed therapy and systemic therapy for options for advanced disease? And do we need to choose? You know, something that all three of us up here talk about is often it's really just a matter of timing. Who goes first? Do we do things in combination? The things that we want to consider are tumor burden, liver function, and then as I mentioned, we always look at efficacy, safety, and tolerability. And then at the end of the day, it's a lot of shared decision-making with patients, having people meet people from all different specialties and having a decision about what to go first. I think what we really need is some biomarkers to decide who's gonna, what patients are gonna benefit from, for example, Y90 up front versus atezo-bev up front, addressing intrinsic and acquired resistance. You know, there still is about 15% of patients who don't respond to atezo-bev. It'd be great to be able to give them Y90 or TACE up front. Studies that inform sequencing, are liver-directed therapies priming for immunotherapy? We need to understand that. Of course, for patients with Child-Pugh B or liver or history of transplant, how can we help them? And then ultimately, we need to, as Riyad was alluding to in the beginning, figure out when is the best time to shift from liver-directed therapy to systemic therapy. Thank you very much.
Thanks, Lipika. That's fantastic. That sets the stage. Let's go ahead and do one quick case. And you heard Lipika talk about infiltrative disease, and that's certainly been something that's been challenging for all of us for a long time. They're probably, you know, worst biology patients, et cetera. But let's take a look at this case here and get some discussions going, including discussions from the audience. If you have them, you can enter those questions. I have that iPad here. So this is a patient, otherwise healthy, that has a 15-centimeter infiltrative HCC, some weight loss, so ECOG performance 1, and some right upper quadrant pain, good liver function, Child-Pugh A, so by definition, Bclc, advanced, as Lipika was describing, and no metastases. So what we have here is a large lesion that's infiltrative in someone that is a candidate for a variety of treatments. So let's start with Dr. Singal, UT Southwestern. How would you guys approach this case?
Yeah, I think the first thing that I'd point out is this is a patient who falls between a B and a C. This is one of the cases that Lipika was talking about, you know, large intrahepatic tumor burden. You know, so one could argue really the decision comes into considering local regional therapy like radioembolization, or is this patient better treated with systemic therapy? I think the first thing is we would definitely present this patient in our multidisciplinary tumor board where we would get an input from all different disciplines. So this decision should not be made on a one-off basis. But otherwise, this patient has good liver function, would be eligible for both systemic therapy and local regional therapy. So, you know, this is someone who basically has infiltrative disease. It looks like it's isolated to the right side. I think it would depend on sort of how much, what his left side looks like, and if you could get away with doing a radioembolization and treating this and seeing how he responds in that fashion. But I think that this would really be a discussion between radioembolization versus atezo-bev, assuming that he doesn't have large varices or a history of bleeding.
Lipika?
Yeah, I fully agree with Amit. You know, I think the issue with patients with infiltrative disease is they're included in all trials and they're part of a subgroup analysis. So it's really hard to really understand how these patients do. So at the end of the day, what's the arterial supply to this and how effective is LDT going to be? They have bad biology, how effective is systemic therapy going to be? We've both seen that LDT and systemic therapy help some of these patients. We've seen both of them fail for some of these patients. So as Amit said, multidisciplinary discussion, both in conference and then with the patient.
And we had one other thing that I just add here is that, you know, much like we recognize that Child-Pugh B isn't a Child-Pugh B, we know that Child-Pugh A's aren't Child-Pugh A's. And so there are now distinguishing features like the LB score that can help you sort of stratify these patients. So one could argue if this is a Child-Pugh A with a poorer LB score, then you may be potentially more likely to use systemic therapy. Whereas if he has a preserved LB score, then you could say like, okay, I'm going to use, you know, radioembolization. So I think some of these factors can help distinguish this, but at the end of the day, I would argue this is an area where we don't have great evidence and there's no right or wrong decision. It's really a matter of expertise. So I think it's a matter of you know, what you have available at your center as well.
Yeah, so for the audience, I think one piece of homework for everybody is to look up the ALBI score. This is a way to get objective information on liver function status, et cetera, as opposed to some subjective components that plague the Child-Pugh score, right? So this is one thing to look up later on. And Amit's very right. I mean, LB1s do well. They tend to be the ones that go to resection in our series, but the twos may be the ones that might benefit for something. As an interventional radiologist, when I see this, I've seen great results with LRT. I've seen fantastic results with atezo-bev in large lesions. I'm the first to admit that. Very surprising, but I have seen it. And so you have to acknowledge that that's what we are now. That's the toolbox that we now have. When I see something like this, I worry about lung shunting. If I'm going to think about tear, this may lung shunt, right? And so this way, maybe I can't get a good enough dose, right? So I really have to think outside the box. And somebody like this may go on to get an angiographic study, and the lung shunt is too high, and then you can't really treat them very effectively. This would go on to systemic therapy. But we all acknowledge, and I will acknowledge, that I've seen great results with systemic therapy with this as well, and I think that's a very reasonable option. Anybody in the audience want to contribute how they might handle this infiltrative? Because one of the things I'm anxious to see over the next 5 years is when people now start to treat these in real life and publish their sort of single series of infiltrative disease. It'll be very interesting how they do. But does anybody have any comments on how they might manage this, or any questions on this case, this infiltrative case? Yes, Suhail.
So, first of all, is there any vascular invasion? And secondly, if you see a high lung shunt, would you not consider chemoembo in that case? Or would you?
Yeah, so the question is about chemoembolization. My bias is that you can't treat this entire thing with chemoembolization. You have to cherry pick, which means you'll by default have some treated and untreated disease, and Lipika and Amit have something that can treat the entire thing at the same time. So this is, I think, with very large lesions, this is where I think you really want to be able to treat everything at the same time. That's my feeling.
One thing that we didn't discuss, actually, once again, depending on what his left lobe looks like, this guy could also be resection. I mean, he's a Child-Pugh A, if his platelet count is fine.
Yes.
I mean, this is the other thing that would be offer him a curative therapy. I mean, high risk of recurrence, of course, but this would be another thing that should be on the table.
We would definitely measure the FLR to see what that looks like. When we do that, if that was our discussion in tumor board, just for everybody knows, and we were going to evaluate for lobectomy, for example, we would do the pressures at the same time. So we do all that stuff at the same time to make sure that all that stuff is prepped in case they end up going to the operating room, because if they have high pressures, they won't get resected. But we do all this stuff up front. So something to think about to compress all the treatments that the patient is going to get. So.
And it could be a great patient for sequencing, where one of us goes first and the other of us goes second.
Yes.
And could you share a little bit about your experience now that you've had a lot of patients who get atezo-bev and then get Y90 in terms of impact on arteries and your ability to be successful after giving bev?
So I used to be much more nervous about arteries with bev. And for some reason, and I don't know that I can entirely explain it, that seems to be much less frequent now. And maybe because we're treating larger tumors, I don't know, but I'm no longer as concerned as I used to be. Now, in other primaries, there seems to be, I think, still a persistent problem. But in HCC, those that are usually chemotherapy naive, and this is not even chemotherapy, right? This is immunotherapies. That does not seem to be a factor. So I have, for example, treated patients that are on atezo-bev, are doing extremely well, and then one lesion is progressing. And that's a PD by the textbooks, but why go to something else when you can just do a focal ablation, an embolization, a Y90, whatever, and maintain the systemic therapy? So I have many patients, actually, that's what we're doing, and we're thinking outside the box, right? Because the theme here is that we have limited treatment options. We want to maximize each treatment and not just reflexively say, oh, one PD means I must switch. The patient's tolerating it well, and you saw the data on the QOL with the atezo-bev. I mean, it's very good. It's a very well-tolerated regimen. Again, new information for all of us to really recognize. So I'm less concerned about the bev, particularly when something this large. Now, sometimes I've seen even atezo-bev and other therapies lower the lung shunt. So like you're talking about sequencing, because what if you get a really good result, but you want to augment that? And this is where I think the tumor board is very helpful, because we can't do everything just waiting for each trial to tell us exactly what to do. We have to have use our clinical experience, apply the best data that we have to the best of our ability. Experience matters, and then see what we can do to sequence, right? I think it's very important.
One other thing that I would bring up is, let's say you do treat this patient with radioembolization or atezo-bev and he has a response. I mean, this is somebody who has liver localized disease right now, And if he has a response, this is somebody, depending on age, comorbidities, should also be considered for liver transplantation if there's a response. I mean, this is, our goal is curative therapies, our goal is long-term survival, and so that's why if we can get these patients to surgical therapies, that's what allows us to achieve those long-term survivals.
So the theme I've noticed over the last 5 years, before I hand the mic over to Dr. Singal for his presentation, is a lot of out-of-the-box thinking now. We're transplanting people that have sustained good response with PVT as initial presentation. All of these things that were initially deemed long ago as absolute contraindications doesn't matter, because as you personalize treatment and you think for the patient here, this is a patient that's doing extremely well, they're 2 years out, the PVT's disappeared, we're gonna think outside the box and do something different. That's the intent of personalization of care, and that's what we did. So here in this case, there are multiple options that we talked about. However, you try to transition either LRT, systemic LRT. The varices is something you need to think about, right? If the patient has not had endoscopy, maybe actually I can ask Amit what his approach is to these patients now, because he's probably seeing a lot of people that may or may not have had endoscopy, and how that relates to atezo-bev.
Yeah, so I think this is actually important. So like what we're making sure is that people are actually up to date with variceal screening. This is standard of care for any cirrhotic, is to have variceal screening. And what we're trying to do is, even before patients require systemic therapy, to make sure if they aren't up to date with their variceal screening when they are diagnosed with their HCC, to refer them early. So we make sure that we have this EGD in hand. And so when they require systemic therapy, we're not then waiting for the EGD. So early getting that EGD done is better. But it is, as Lipika pointed out, it is important for us to do this so we continue to risk stratify these patients and minimize the GI bleeding we're seeing in clinical practice.
So in your tumor board for the interventionalist, the EGD component is a factor, is a variable to receive atezo-bev. That's something you got to be thinking about. So Dr. Singal, I think, So the next, again, at this point, next polling question, please take a look at that. Answer that question on multidisciplinary management with infiltrative disease, what you would do at your center, LRT, combined, systemic, whatever order that is you are provided, and answer that question. So now it's a pleasure to introduce Dr. Singal, who will be talking about optimizing decision-making of local, regional, systemic therapy. Amit?
Thanks, Riyad. So as Lipika and Riyad both pointed out, it's always nice to do these because it really does highlight the multidisciplinary nature of HEC decision-making, as you also saw from this last case. So I'm going to start just with emerging multimodal approaches in advanced HCC, and then I'll quickly pivot to earlier stages of disease. So one of the other interesting areas that's coming about is this concept of TT fields, which is being used in combination with systemic therapy. So I think many of us probably haven't heard of this before, but this is something that I think is promising and interesting as an alternative therapy. So TT fields are alternative electric fields that can disrupt charged particles during mitosis, lead to cell death in dividing cancer cells, spare quiescent cells, so spare non-tumor cells, and may augment what we see with systemic therapies. So we're going to start with just a brief video reviewing how TT fields work, and then I'll go over the data for what's available in terms of advanced stage HCC. So I think we have a video now.
In metaphase of cell division, cells are a rounded shape as the mitotic spindle forms. Intracellular components such as macromolecules and organelles are naturally charged. Tumor-treating fields, or TT fields, disrupt cancer cell division by physically interacting with molecules required for mitosis. When alternating electric fields are applied to cancer cells, they disrupt microtubule polymerization. Tubulin dimers align with the electric field and are not able to form microtubules. This prevents the organized assembly of the mitotic spindle required for normal cell division. The inhibition of microtubule formation leads to metaphase arrest and cancer cell death. In addition, these deformed microtubules can lead to abnormal DNA segregation between daughter cells, which also results in cancer cell death. TT fields can also affect cells after metaphase. If a cancer cell has passed metaphase and enters the cytokinesis phase, the cell takes on an hourglass shape. This state under TT fields creates a non-uniform electric field inside the cell, creating dielectrophoresis. Net forces push the macromolecules and organelles toward the mitotic furrow, and this disruption leads to structural disorganization and cancer cell death. Transducer arrays can be placed on the scalp, chest, or torso to deliver TT fields that kill cancer cells. The placement of transducer arrays is personalized for each patient.
So you can see that this is sort of an interesting concept and very different than some of the other therapies that we use for cancer in general and for HCC. And these tumor treating fields are frequency tuned, so they really are targeted to specific types of cells. And so you can see here you would adjust the frequency depending on what type of cancer you're treating. And the nice thing is, once again, this is part of the reason why it's able to spare these quiescent cells and be relatively well tolerated. So this has been evaluated in a phase 2 study, the HEPANOVA trial in advanced stage HCC. So this was done in 27 patients in combination with sorafenib. And you can see that TT fields plus sorafenib was able to induce fairly high rates of disease control rate of 91% and objective responses in 18%. Now, as you heard, there's clearly been advances in the systemic therapy field, and now atezobev is the preferred therapy in the first-line setting. And so now there's a phase 3 trial in combination with atezobev and tumor treating fields, and this has been granted FDA breakthrough therapy designation. So we will probably see these data come out in the next several years. So I'd like you to take a moment in terms of another polling question about tumor treating fields, and while you're doing that, I'll go on to earlier stages of disease. So, of course, I don't have to tell anyone here that the AASLD and other societies recommend local regional therapy for many patients with Bclc stage B disease, so liver localized disease that are not amenable to surgical therapies. And the AASLD does not recommend one form of local regional therapy over another. So here, chemoembolization, radioembolization were both thought to be equally efficacious in terms of overall survival, although once again, several people have shown that the progression-free survival and time to progression is significantly longer with radioembolization. So we also recognize that there are prognostic scores that can separate out these patients with intermediate stage disease. One of the prognostic scores here is the 6 and 12 prognostic score. Not saying that this is the best, but this is just one of several that have been proposed. What this does is it adds the largest tumor diameter plus the tumor number, and when you add these two components, you get a linear score up to sort of however high that number may go. Basically, if you have a lower score, your prognosis is better. The higher the score, the prognosis is worse. So you can see if you have a score of 6 or less, that your median survival is around 49 months versus a median survival of only 16 months for those that have a sum greater than 12. And this may help determine who are the best patients for local regional therapy, whether chemoembolization or radioembolization, with the idea that if you have a lower score, sort of less number of nodules and lower maximum tumor diameter, that you may have a better response to local regional therapy. And these patients with large tumors or multifocal bilobar disease having a less likely chance of good response to local regional therapy. Now, as you heard, this is a complex decision. It's not like you can simply use these single scores and say, oh, the sum is 16, and so I'm going to go on to systemic therapy. It really does depend on the distribution of disease, et cetera, in terms of what your likelihood of response is and your tolerability in terms of your decline in liver function over time. But these are some ideas in terms of who may be better treated with local regional therapy versus systemic therapy or combination therapies in the future. Now, the other thing that we have to talk about, and we've referenced this in the prior tumor board discussion, is liver transplantation. Once again, liver transplantation being one of our curative options for patients with HCC. So for patients who undergo liver transplantation, we know that we can achieve 5-year survival well beyond 60%, and many patients achieving decades of life. As we had mentioned, we used to be restricted to the Milan criteria, so 1 tumor, 5 or less, or 2 to 3 tumors, each less than 3 centimeters. But now we are able to extend the benefits of liver transplantation to more and more patients. And so we have the concept of downstaging, which I imagine many of you are already familiar with, in terms of having larger intrahepatic tumor burden. For example, a single tumor up to 8 centimeters who gets treated with local regional therapy, then comes within Milan criteria and is then able to undergo liver transplantation. Furthermore, even if patients are beyond this UNOS downstaging criteria, so liver localized disease or small vascular invasion has a good response to local regional therapy, you can still perform liver transplantation via a living donor liver transplant pathway. Really what this means is that local regional therapy can be a nice bridge or a downstaging approach to achieve liver transplantation, once again highlighting the communication between the two disciplines. Now, when we think of intermediate stage disease, you also saw this in terms of a debate between systemic therapy versus local regional therapy. And this clearly comes into these quote-unquote B- patients, right? These patients who are Bclc stage B, but with larger intrahepatic tumor burden. This was a propensity matched analysis where Kudo and colleagues compared those patients with larger intrahepatic tumor burden who were first treated with systemic therapy, in this case lenvatinib, versus local regional therapy, in this case chemoembolization. And what the authors found here was surprisingly, in my estimation, the survival was longer with systemic therapy than with local regional therapy for patients with large intrahepatic tumor burden. And this was most related to smaller decrements in liver function over time. Now, this was a retrospective analysis, propensity score matched, and so far from conclusive, but this is now leading to large phase 3 randomized control trials that are specifically evaluating this question of systemic therapy versus local regional therapy for these patients with large intrahepatic tumor burden, 2 of them being listed on the slide here. Now, of course, this doesn't have to be either or, right? So it doesn't have to be local regional therapy versus systemic therapy. There has been discussions of combining the two in terms of our approach to intermediate stage disease. So there, in the past when we were restricted to sorafenib and then lenvatinib, there was thoughts of moving TKIs to earlier stages of disease, and there's rationale for doing this in terms of, changing the angiogenic switch here, and then also impacting VEGF surges after you treat with local regional therapy. So, there is preclinical rationale for potentially a benefit of TKIs combined with local regional therapy. However, all of the studies that have been done in this space fail to show a significant benefit of doing so. So we have several large trials here which basically fail to show significant improvements in time to progression, overall survival, or progression-free survival. And so this really has, unfortunately, dampened our enthusiasm for at least local regional therapy plus TKIs. Now, of course, with the introduction of immunotherapy, this is now being sort of reassessed. There is the thought of releasing neoantigens, potentially augmenting immunotherapy effect when used in combination with local regional therapy. We see some of this once again already with the abscopal effect, where if you treat with local regional therapy, you may see induce immune responses in untreated lesions. And so this is now being approached in terms of combination trials moving forward, several of them ongoing, as you can see listed here, using different combinations of systemic therapy plus local regional therapy. And so we anticipate these reporting out over the next couple of years. I don't think that this should be done outside of a clinical trial routinely at this point, but once again, we do anticipate these data coming out over the next couple of years. Now, briefly moving on in terms of moving from the local regional therapy space to earlier stages of disease. We know that there are surgical therapies that are available for patients with early stage disease, namely hepatic resection being one of these. Hepatic resection is primarily reserved for patients with good liver function, Child-Pugh A, and no portal hypertension with a platelet count typically greater than 100,000, although this is now being reassessed with the availability of laparoscopic or robotic approaches, minimally invasive approaches to hepatic resection. So if somebody's doing a small resection, one can think about doing this in patients with minimal portal hypertension, as long as the future liver remnant is sufficient. However, although resection is curative, there are high rates of recurrence that can be up to 50 to 70% at 5 years. And unfortunately, at this time, we have no proven adjuvant therapy. So much like we saw with the local regional space, there were trials that looked at the combination of TKI therapy after high-risk recurrence patients. Notably, the STORM trial looked at sorafenib in patients who were high risk of recurrence after resection or ablation, And unfortunately, this trial failed to show a benefit of TKI therapy in these high-risk patients. Of course, everything's being reassessed now that we have more effective therapies in the systemic therapy space. So we see these systemic therapy agents being diffused down to earlier stages of disease. You can see several of these trials listed here, looking at different systemic therapies being evaluated after resection or ablation. And we anticipate these studies reporting out as early as later this year. Now, of course, we've already heard about how immunotherapy has completely transformed the systemic therapy landscape, but we anticipate that these will diffuse down into earlier stages of disease. So this is no longer the time where we can be like, I don't need to know about immunotherapy or PD-1s and CTLA-4s. This is something where we will probably all have to understand these immunotherapy combinations and how it impacts our sort of individual practices. Now, we talked about the adjuvant setting. There are also interesting early studies looking at this in the neoadjuvant setting. So you can see here a small study that came out of Johns Hopkins in terms of taking patients who were borderline resectable, taking a look at the combination of cabozantinib and nivolumab, so another combination of IO plus TKI. And what they were able to show is that this combination was able to sort of quote-unquote downstage or make borderline resectable patients surgical candidates. And we can see that there was notable responses in a significant proportion of these patients. And those patients who had a pathologic response clearly did better than those patients without a pathologic response. So interesting data, once again, that this may not only be adjuvant, but potentially neoadjuvant in the future. Once again, larger studies planned for the future. Finally, immunotherapy, the sort of interactions with transplantation have always been a little bit concerning. We know that if immunotherapy is used after transplantation, there's a high risk of graft loss, there's a high risk of mortality, and so this has historically not been done. Interestingly, there were data coming out of Mount Sinai that showed that patients could receive immunotherapy even within the month of liver transplantation, and those patients appeared to do fine after liver transplantation, at least in the early period. And there are now studies ongoing in terms of taking patients listed for liver transplantation and potentially bridging them with immunotherapy. I would say that this definitely should not be done outside of a clinical trial. I do think that this is interesting, although potentially risky. And so I think that there are going to be data that are necessary in this space and understanding how immunotherapy can be used potentially pre-transplant, although I would argue still not used post-transplant. Finally, you've heard this before, and I imagine you will continue to hear this throughout the presentation. Multidisciplinary care is critical for these patients. It's not just a feel-good concept, and it's not just highlighted by the fact that all three of us are here discussing cases and going over this. This is highlighted by data, including data from our center, that shows that this improves clinical outcomes. This basically improves guideline concordant treatment, it improves time to treatment, and most notably, there are several studies that show that this improves overall survival. So not just a feel-good concept, this should be regarded as standard of care for our HCC patients, and will be only increasingly important as we see the silos of HCC care completely being broken down. You're going to see transitions going from the right, so patients stage migrating to the right, as well as being stage migrating to the left in terms of downstaging, increasing combinations. So this is going to be increasingly important as we move forward.
Thanks, Simon. That was fantastic. Thank you very much for that overview. So this is perfect. We have about 15 minutes left to go through some cases, and again, hoping for audience participation. I got some questions here, but before I go through, I want to ask Lipika and Amit. Can you tell me a little bit? There's so much going on now in categorizing the IOs and then the TKIs. With so much that's coming out and it continue to come out, are you going to categorize IOs, then switch to TKIs and back and forth? Are you going to stick with IOs? How are you thinking of managing that? Because you're going to have a lot of options available to you, and this is sort of like a combination of multiple questions. How do you plan to navigate by categories? How do you plan on tackling that?
Yeah, it's a great question. I think part of it is seeing the data that are coming out from new frontline trials, seeing, there's a lenvatinib pembro trial, that's a combination trial, there's an ipi-nivo trial, that's a combination trial, and of course we have atezo-bev and durva-tremi. And so when someone has had a TKI and immunotherapy in the front line, or VEGF-directed therapy and immunotherapy in the front line, your question is exactly the question we ask ourselves in Med-Onc clinic, which is after someone has progression on a combo, what is plan B? And so there are different sorts of prospective trials and also retrospective chart reviews looking at what's effective after atezo-bev. I think still to be determined in terms of what's the optimal next choice. I think a lot of us use sorafenib or lenvatinib and then go on to other drugs. A lot of people also use ipi-nivo next. I think this is a space where we need novel therapies, and I think there's a space where we need biomarkers. And certainly a place where, because we don't have a standard in the second line, thinking about combinations where we have liver-directed therapy next and or in combination with systemic therapy. I think that as I've spoken at different IR meetings, when you give systemic therapy, people feel like a patient because they're coming to see you every 2 weeks, every 3 weeks, every 4 weeks. And all the IO companies are working on switching Q2 week regimens to Q4 week regimens with higher dosing, or Q3 week regimens to Q6 week regimens. But one of the beautiful pieces of liver-directed therapy is you treat, and then people often have 6, 8, 12, sometimes 2 years, months or 2 years where they don't have to actually come and see you as much as just for surveillance. And that is a huge thing for patients.
Amit?
Yeah, I think, I completely agree with Lipika, and I think this is a data-free zone. And I think that's really because all of these trials were done in comparison to sorafenib in the frontline setting, or lenvatinib now with the LEAP trial. And all of the second-line trials were done after sorafenib. And so there's really no data to say what we should do after our now current first-line therapy. So there's no data to show what's the best therapy after atezo-bev. There's no data to say, should you go on to a combination of, should you use a TKI therapy, or should you use, combination of PD-1, CTLA-4. So we don't really know what the best therapy is, and the way that I look at this is just do something. So the key thing is not to do nothing. So what I would say is, at this point, with the lack of direct comparative data, I think there's almost something available for almost every patient outside of a Child-Pugh-C. So we have data for sorafenib and lenvatinib now in terms of Child-Pugh-B data showing tolerability. We have data for nivolumab in Child-Pugh-B patients. So even if you have a Child-Pugh-B patient, you can theoretically choose something. And if you have a Child-Pugh-A patient, you have multiple sort of agents on the sort of table. But I think that simplistically, I'd say if I use atezo-bev in the first line, we tend to use a similar sort of sequencing strategy right now in terms of going on to the old first-line therapies, sorafenib and lenvatinib, and then going on to the prior second-line therapies. This will only become increasingly complex as we have more and more first-line therapies to report out.
So speaking of that, it's a perfect segue. Would you agree, to be maybe slightly controversial, maybe not so slightly controversial, that because of all the information that we're getting at such a rapid pace, we may need to commit the ultimate infraction and perform cross-trial comparisons? Your thoughts?
I mean, I think this is the art of medicine. I totally agree.
I like it.
The pros of that is those are the data we have, so we have to use them. The challenges of it, of course, are that the baseline populations can often be different. So looking at the table ones across different trials, and and some of the trials are much more global than others, and some of them have a greater population of Asian patients than others. They have different mixes of patients with hepatitis B. They have different mixes of patients with portal vein thrombosis. But ultimately, we work with the data that we have, so we certainly do cross-trial comparisons.
Yeah.
I completely agree, and I think that not only comparing the demographics of those patients, but also looking at post-progression treatment.
Yeah.
So we have to understand that a trial, for example, the IMbrave 150 trial, versus trials that are subsequently done, there are going to be patients who are on that trial who then receive atezo-bev in the second line.
Yep.
And so it's not like you're only competing with what you receive in the first line. You're competing with first line plus all of the post-progression treatments.
Yep.
And so it's going to be tough. The sort of post-hoc sort of analyses of these trials are going to be fascinating. And I don't know, but we're going to have to do some kind of cross-trial comparisons, but it's not just going to be 19 months versus 17 months. It's going to be the type of thing where you're going to have to really understand the nuances of these data to understand what those cross-trial comparisons and potentially post-hoc analyses and subgroup analyses really suggest.
So you just heard two, I think, very important learning points, which is, in my opinion, when I'm reading an HCC manuscript, the baseline characteristics table, I spend 50% of the time on who are these patients? What are the etiologies? Where are they from? How much disease is there? What's their liver function? It's a very important component of reading any manuscript, because that will then set the stage as to what you are seeing, number one. And number two, post-progression. Post-progression. All of these patients are getting post-progression treatments. We need to know what they are. Some improve survival, right? So that affects overall survival. So notice that, read that. It's a very important component. Amit, go ahead.
You know, you and I have talked about this as well. I mean, there's stuff in the table 1, and then there's the stuff that you wish was in the table 1,
Yes.
right? So, I mean, table 1 tells you you have extrahepatic spread and you have portal vein thrombosis.
Yes.
It does not tell you the degree of intrahepatic tumor burden. And those things are critical. So you can imagine somebody who has a single lymph node but who had a complete response within the liver to prior local regional therapy is very different than somebody who has bilobar multifocal involvement plus a portal vein, sort of an extrahepatic met.
Right.
But both of those patients are in the extrahepatic yes category.
Yes.
So there's so much nuance to this that you don't see in a table 1 that can make cross-trial comparisons very dangerous.
And that stems from a lot of the trials historically being based on unresectable, not amenable to TACE or Y90 or whatever, and that category has become sort of the detail has been lost. And I think that's part of the component that really needs to be elucidated in contemporary trials is, where's the disease, right lobe, left lobe, bilobar, how many tumors, what size are they? Because if we're going to look at things like what Kudo is doing, then we need to look at all that stuff from the baseline characteristics as well. Because at the end of the day, that's what we do at Tumor Board. Look at these large tumors, look at this bilobar disease, this trial did the same, this is how they did. So that's I think, those are great teaching points for everybody looking at HCC data. So let's take a look at this case here. This one may be a little spicy and hopefully get a little audience participation. So now we have an infiltrative tumor again, but this one specifically infiltrative due to the vascular invasion. So right portal vein thrombosis, good performance status, ECOG 0, doing well, normal liver function, Child-Pugh A, but Bclc C because of portal vein thrombosis. So let's start with Lipica. So same family, except this one is specifically PVT. What are your thoughts on this one?
So this is classic Bclc stage C. It fits right into the category of the patients who went on to atezobev and went on to durvatremi. So I think certainly a standard would be reasonable to think about atezobev and durvatremi. To be very honest, I think the answer is very similar to the answer with the infiltrative HCC case that we had before, in that atezobev would be certainly standard here, but there are several patients who have this picture, especially if the tumor is, let's say 7 centimeters or something like that, who do very well with liver-directed therapy, and if it's not a large tumor burden. I like to see the AFP as well,
Okay.
But very similar conversation.
Okay, Amit?
Yeah, I agree with Lipica. So, I think that obviously, the prior slide said no metastasis. This one, I would definitely do a metastatic workup.
Yep.
Like to see the AFP. I think a very similar sort of discussion. Instead of like a B minus, this person's a C plus. So like just on the other side of this in terms of, But I think that it still comes down to something like radioembolization. Potentially surgery if the patient had, once again, extended sort of indications here in terms of if the patient had an adequate platelet count, versus systemic therapy, atezobev or durvatremi. I think that, in contrast to the other one where if it was a tiebreaker, I'd be like leaning a little bit more towards radioembolization. This one, I'd be leaning a little bit more towards systemic therapy, but I think you could go the other way.
So we are in, when we mix and match, we are in a data-free zone when we do this sort of stuff. Would you think it would be unreasonable to start with, say, an LRT, probably Y90, I would think, with PVT, and then plan, again, data-free zone, we don't have data on this, but because the tolerability of each treatment in Child-Pugh A is very good, would you think that's unreasonable to start with an LRT like Y90 and then go on to systemic therapy at, say, day 30, which I think probably many people in this audience would like to do? Or do you think that's, the data just doesn't support that, or it's too data-free and just a little too freewheeling? How data-free is that?
I would say that it's not unreasonable, but show me a phase 3 trial.
Sure, okay, I'll work on that one.
Yes.
Yep.
I would say we certainly do that in our tumor board. We have, we do radioembo for a case like this and do atezobev next. But I think the more we make that commonplace without having data, the less we're really going to be able to see if that approach is the best approach to do.
That's fair.
And so,
Amit, what do you think about that
Yeah,
approach?
I guess, I agree. So data-free, not necessarily wrong. I think if I were to do that, I would try to get this patient on a clinical trial. I think that's the best way for this patient to get this combination, if that's sort of truly what was desired. I think it would, in part, also depend on sort of the age, sort of the comorbidity, what's the intent here. And so, I think that the one sort of downside, potentially, of doing this approach is that there are some patients who you treat with local regional therapy, and even though the intent is to do this selectively, the patient then has liver dysfunction and then is not as sort of clean coming into systemic therapy. So that's the only downside to be in my estimation, outside of data-free. But that's really the downside in terms of potentially that approach.
So that's a great teaching point, right? One of our obligations as we do LRTs is to make sure that the patient can benefit from all treatments. You have to be careful. You can't, taste whole livers, right lobes, left lobes, Y90s, everything sort of willy-nilly without recognizing that at some point they're going to progress, they'll need systemic therapy, and you can't present the patient who's a Child-Pugh C10, for example, for systemic therapy. So this is this very, very important interplay. We are an interventional radiology audience. Out of curiosity, how many in the audience would start with a systemic therapy for a patient with this portal vein thrombose? Who would start with systemic therapy? Okay, who would start with an LRT followed by systemic therapy? We have a lot of, now, what about, we've only got about 8 votes, so everybody, I don't know what everybody else is doing, still thinking about it. Anybody wanna propound on what they would do with this patient?
Clinical trials never.
Clinical trials is a good answer, always a good answer. Send to Mass General or UT Southwestern, that's a reasonable answer. Anybody disagree with that or think that we've missed one of the discussion points? Okay, we'll continue to the next case. Thanks, guys. Let's go on to, I'm just making sure I'm capturing all the questions that are being asked. Okay, this one's a little bit different. So this is a 4-centimeter tumor, dome, and has some weight loss, lost 10 pounds or so. Good liver function, Child-Pugh A, but is a Bclc C, so advanced disease because of the weight loss. So no PVT, no metastases, has that lesion in the dome, and let's assume that the surgeon has looked at it, there's portal hypertension, not resectable, probably could receive transplant at some point. So comments on this 4-centimeter dome lesion? Lipka.
so this is where I was mentioning the 3 flavors of Bclc stage C. I personally do not make decisions based on ECOG performance status in terms of calling those patients C and moving towards systemic therapy. My first choice, as Riyad was saying, is asking surgery what options we have. And here we take into account, what's the reason for liver dysfunction? Do they have Hep B? Do they have Hep C? Do they have a background of cirrhosis? Do they have a field defect where they're likely to develop more HCCs, in which case we push more towards transplant than surgery? It sounds like the patient has portal hypertension, so surgery is not an option. So certainly would favor moving down a transplant pathway for this patient. So liver-directed therapy followed by transplant.
So LRT, trying to get to transplant for this patient. Important point that Lipika mentioned, she puts less weight on the ECOG component of Bclc than PVT and metastases, which are a bit more objective. Amit?
Yeah, I think I agree completely. I think LRT and then bridge to liver transplantation, 100% the way to go with this patient. I guess I'm a little bit surprised, relatively small tumor that the patient presents symptomatically. And so I would be I'd be worried that this could be an aggressive tumor. I'd sort of once again be interested in seeing the AFP here. Obviously needs a metastatic workup. I just, unlikely with the small tumor size, but just it looks like a potentially aggressive tumor.
So that's a great point. So I said, well, look, you got 4-centimeter tumor. Why is he an ECOG 1, weight loss, et cetera? Is that really true? So I'll be honest with you. In our analyses, in our databases, when we give performance status, we give the performance status that medical oncology assigns. And that can be challenging, and sometimes we're like, wow, it's a 3-centimeter tumor, but there are other things going on that the patient was assigned an ECOG 1. It's not the cleanest, but that's what happens. And so I fully admit that some of our data are probably confounded by that artifact, that are they really a 1?
Yep.
Not really the true spirit of the 1 in the Bclc, and that's an artifact we have. But is there a question?
I may be ignorant, but I'm trying to understand the weight loss and all the systemic symptoms on a 4-centimeter solitary lesion in the liver.
Yeah.
Could you teach me?
I wish I could teach you, but that's
So-
what I just,
well-
mea culpa, that I don't know, but I mean.
Yeah, I think the one thing, so when we think of ECOG performance status, this is my sort of perspective on this, it's easier in other cancers where it's cleaner. They have a cancer. And then you can assign the ECOG performance status. I think it's always tough with HCC because you have HCC and then you have the underlying liver disease. These patients are often comorbid, et cetera. And so I think the other thing is sometimes people misassign an ECOG performance status, and there's another reason for this weight loss. It's not really cancer-related cachexia. It's really weight loss because the patient has some other, they have ascites, or they have something else that's driving the weight loss. So I actually think Riyad's right. I think the ECOG performance status is often misrepresented and poorly assigned for these patients, and that's why we need better objective measures, much like the LB score, for example, instead of the Child-Pugh score, in terms of assessing some of this functional status. It's not as clean in HCC. But that being said, we have some recent data that does show that cachexia can even occur in some patients with early stage disease. Once again, it may relate to tumor biology. So we know that not every tumor grows at the same rate. There's sort of the cars going down the sort of highway at 70, and then there's the cars going 100. And this may be one of those cars going 100 miles per hour. And so it may just be a fast, aggressive tumor that, if you really believe the weight loss and the ECOG-1 is related to this tumor, may really highlight that this patient's at increased risk of progression after treatment, and so just may impact your treatment decisions.
For the purpose of the Bclc, it's supposed to be cancer-related weight loss, specifically attributed to this. But there are many patients that walk in that are, not ECOG zeros for a variety of other reasons, and it's very hard to say, yeah, but you're a 1, but not really a 1 because of this. And so I remember in some of our databases we have Bclc stage with and without ECOG, like believing it or not believing it.
Yeah.
And so this is sort of one of these things. So it can be very challenging, but again, brings you back to the multidisciplinary tumor board about all this discussion. It's like, look at this. This is guy ECOG-1, technically advanced, but we want to get them to transplant. We're going to apply an LRT to bridge them to minimize progression, right? Important concept in the tumor board. We've got 2 minutes left. Let's do that last case. So this one is actually I remember this patient, an asymptomatic patient with a large tumor. He was in his mid-40s, slightly elevated liver function, but a large tumor, Child-Pugh B. So, Amit, any thoughts on what are you doing now with patients that Child-Pugh B?
Yeah, so, we sort of referenced this before. A Child-Pugh B is not a Child-Pugh B. I see his Billy's 2.1.
Yeah.
I don't know if he's otherwise compensated or decompensated, but he said he's in his 40s.
Yes.
I mean, very young guy.
Yes.
This is somebody we'd be personally aggressive with. This is somebody where we would treat with local regional therapy, assuming he's not a B9.
Yep.
Assuming he's on the healthier side of the B, maybe a B7. This is somebody we would treat with radioembolization, and we would consider downstaging. So he's beyond UNOS downstaging. We would look for a living donor for this patient. So we would treat with radioembolization and then try to get him listed for living donor liver transplantation.
Okay, Lipika?
Yeah, I would say very similar answer. I would say the data for systemic therapy, I think there's a Nobel Prize waiting out there for anyone who can cure cirrhosis and reverse it, because it's certainly the main issue that we deal with in HCC. So if we can get this guy on a curative pathway, that's our first choice. Amit mentioned a little bit earlier, there's some prospective data with sorafenib, there's some data with lenvatinib, and of course there's prospective data with nivolumab as well. But the efficacy is still modest in Child-Pugh B. So if this is the only tumor that the patient has, would certainly support upfront liver-directed therapy.
Can you teach us a little bit, just as a final thought, about, again, data-free or moderate data, but on the safety of the IOs in Child-Pugh Bs compared to the traditional chemotherapies?
Yeah, so the study with nivolumab, it was in patients who have B7 or B8. They could not have had a Billy greater than 3.0, and they couldn't have had decompensated cirrhosis with like ascites requiring paracentesis. And so luckily, the hepatic dysfunction was not higher in that cohort than in the Child-Pugh A's. So safety-wise, it was quite similar. And the response rate was also like relatively similar, but lower, But it's certainly something that if this patient had a systemic disease, that would be my first choice.
Amit?
Yeah, I think the other thing that we're also seeing now is we're seeing more and more real-world data come out with the Tezo-Bev and extended patient population. So you talked about, the IM grade 150 trial, sort of clean population, Child-Pugh A, had their EGD, et cetera, et cetera. And so now we've seen several publications come out in terms of real-world data for Tezo-Bev. And so we're starting to see expansion of atezobev in well-selected Child-Pugh B patients, B7 patients, and this being relatively well-tolerated in the data that are reported. Maybe selection bias of who actually reports this. Imagine the centers who are doing this and like having terrible outcomes are like, we're gonna hide those data, but like there are some real-world data in terms of extended use of these new combinations in Child-Pugh B patients as well, and so I think we're gonna start seeing this and feeling more comfortable in well-selected Child-Pugh B patients with these new combinations.
So I think the teaching point is, at least for some of these IOs, it's a discussion point if you have Child-Pugh B disease. It is an option. It's not always an option, but it's more in the discussion than it used to be. So if you could please take a moment to answer this follow-up question on the personalized multidisciplinary management of HCC. I think we've taken a couple of questions, and I've answered a couple of these already, and we are out of time, so next slide, please. So I think I'm going to start wrapping up. Is that correct? I think so. So please visit the PeerView website, as you can see there. Complete and submit your post-test and evaluation for credit. You can download the slides and practice aids, and you can watch the replay of this event in the next 24 hours and the online activity in the upcoming weeks. I'd like to thank everyone for their attendance. I'm glad you had a great SIR meeting. Thank you, Dr. Goyal, Dr. Singal, for joining us today. I hope you found this helpful, and thank you, everyone.